All right, so good afternoon, everybody, and welcome to the Shift Connect conference. My name is Victoria Hamilton, and I am one of the students in the conference course this year. On behalf of our class and our professor, Dr. Ren Thomas, I'm pleased to welcome you to this event hosted by the School of Planning at Dalhousie University. I would like to respectfully acknowledge that we are grateful to be able to live, work, and play on Mi'kma'ki, the traditional and unceded territory of the Mi'kmaq people. We thank our Dalhousie University Elder in Residence, Jerry Masca-LeBlanc, for opening our conference with a blessing this year, as she has done in previous years. I'd also like to take this opportunity to thank our sponsors, the Atlantic Planners Institute, the Licensed Professional Planners Association of Nova Scotia, Turner, Drake and Partners, FBM, Fathom, ZAP, and the Dalhousie University's President's Office. I'm pleased to welcome today Dr. Kate Mulligan. Dr. Kate Mulligan is a health geographer and policy professional with a critical public health orientation and a strong interest in advancing healthier and more equitable communities. Based in Ontario, Canada, her research and policy work has been supported by Toronto Public Health, the Ontario Ministry of Health and Long-Term Care, Health Canada, and the United Nations. Until recently, Kate was the Director of Policy and Communities at the Alliance for Healthy Communities, leading at the forefront of Ontario's health systems transformation to advance health equity through 100+ community-governed, comprehensive primary healthcare organizations. Kate is also an assistant professor at the Dalla School of Public Health at the University of Toronto. She is a partner on the Dalla School of Public Health's project on public health training on Equitable Systems Change and a contributor on Health Canada's 2021 Climate and Health Adaptation Assessment. Kate is also the director of Ontario's first social prescribing project, which is implemented in community health centres across diverse urban, rural, Francophone, and northern regions in the province. This initiative aims to improve health outcomes for marginalized and socially isolated people and to reduce health systems utilizations by creating a clinical pathway between mainstream health system and community and voluntary supports, which has been showing promising results that have gained wide interests nationally. Kate continues to work towards healthier cities and communities through research, mentorship, and action on healthy public policy, political ecologies of health and well-being, climate and health equity, and upstream health systems interventions. We're so excited to be able to have someone with your expertise join us as a keynote speaker for the Shift Connect conference. So just before I hand things over to Dr. Kate Mulligan, there's just some housekeeping items. So as you're all aware, we are using the Zoom webinar platform. So this allows only the moderators and the keynote to have access to their microphones and the sharing screen options. So if any of the attendees have any questions during Kate's lecture this afternoon, please feel free to type them in the Q&A box at the bottom of your screen, and we'll be sure to get to them during the Q&A period. I also have Travis Nickel and Eric Lindsay with me this afternoon, helping with any tech and moderating the chat box as well. So with all of that, I'll now hand things over to Dr. Kate.
Thanks so much, Victoria. And thank you to all of you for having me here with you today. It's a real privilege to be here to talk about syndemic sensitive planning and some of the work that I think holds a lot of promise in community-led health promotion and social prescribing. I want to begin by recognizing that I'm coming to you today from Toronto, which is the traditional territory of many nations, including the Mississaugas of the Credit under Treaty 13, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. And it's now home to many diverse and leaderful First Nations, Inuit, and Métis peoples. So what does it mean when I say that COVID-19 is a syndemic? It means it's more than just a pandemic. It's a synergistic pandemic, something that clusters and intersects with other pre-existing health conditions in populations. And these, in turn, are exacerbated by social, economic, and political environments, including our colonial and industrial legacies. And so that means that, the hierarchical approaches of colonial eras, the one-size-fits-all approaches of industrial eras have not served us well during COVID-19. And what we need instead is a complex adaptive systems approach. And that's actually much simpler than it sounds. It means we need to invest in a great deal in what happens at the community level in order to get a fine-grained, locally specific set of feedback in a community-led approach. And this is something that I hope you'll be able to take forward with you in your careers in planning. So forgive me for focusing on Toronto for a few minutes in these maps. As Victoria mentioned, I'm a geographer by training, interested in why we have health disparities between neighborhoods, between different places, for example. Toronto is where I live, and it's where I sit on the Board of Health, and have been active in trying to make sure that we are able to address COVID's health inequities through transparent data sharing and community level action. So even if you're not familiar with the geography of the city of Toronto, what I want you to do for the next few slides is just keep your eye on the northwest corner of the city, the top left-hand side of the screen. You can already see that it's in a dark blue color. That means it's been more heavily impacted by COVID than most other areas of the city. Generally speaking, the outer suburbs have been more affected than the inner parts of the city, the downtown, but it's been particularly notable in that upper northwest corner. And given what we know about syndemics, we shouldn't be particularly surprised. So I'm going to show you a few maps of the pre-existing conditions from before COVID that help us predict this outcome. This is a map of working poverty, the percentage of working poor individuals. And you can see, again, a bright red color up in that northwest corner and throughout several of the outer suburbs. These are the people who have been called essential workers and don't have the option to isolate at home. They've got to go out sometimes into very high risk working conditions in long-term care facilities, in manufacturing, in delivery, and so on. Here's a map of precarious housing and the racialization of our city, the racial segregation that happens here. So it's a map of both Black Torontonian renters and the eviction filing rate, showing significant racialization of housing impacts here in the city. And again, you can't isolate at home if you don't have a home or if you're being evicted. And the rules around evictions have changed throughout the time of the pandemic. Here's a map of built environment and transportation barriers. It looks like almost the inverse of those other maps that we were seeing. It's a map of walkability, and I could show you many other environment and transportation related maps that would look quite similar. And we can see that there's very poor walkability in that northwest corner. There's also poor transit access. People have to get to those essential jobs by public transit, typically by bus that is infrequent and crowded. Here's a map of food insecurity showing food bank use per capita. And again, that northwest corner is highlighted. This map shows the digital divide and those people who are worried about their ability to pay their home internet bill. This is important for people who are working from home, educating children from home, accessing health and social services from home, and so on. And will become increasingly important as our services and our lives continue to move online. So not surprisingly, many of those underlying conditions have led to significant chronic conditions that we know are also risk factors for COVID-19. So this map shows diabetes, heart disease, mental health and addictions. This map shows access to mainstream healthcare, family health teams, which are group-based primary care clinics doctors, nurse practitioners, dietitians, health promoters working together under one roof. And you can see, again, it's almost the inverse of that risk map of those heavily syndemic affected areas. This is because healthcare systems are disincentivized to serve the most marginalized people. Those marginalized people face significant medical and social complexity that isn't well addressed by mainstream healthcare. And so these clinics have set up wherever they wanted, which typically is in higher income and more stable areas. So all those add up to something not particularly surprising, that we have high rates of COVID among Black and racialized people, essential workers, people with precarious employment and housing, living all in that northwest corner of Toronto. And I want to really stress that this is not because of some kind of inherent flaw or deficit in this particular population. It is because of long histories of injustice that have led to this particular geographic makeup of the city, that have led to inequities in the labor market, the housing market, access to care, and so on. On the bright side, this map isn't great, but it does show the location of community health centers. These are comprehensive primary healthcare organizations whose mandate it is to serve those people facing the biggest barriers to health and well-being, the populations who face the greatest inequities in health outcomes and health access in our province and across Canada. And so you can see that CHCs are located in the communities that need them most. That is their mandate. And they have evolved over many years a particularly strong capacity to do this work in an anti-oppressive, culturally safe, and trusted way that's highly resilient, highly nimble and adaptable, and reflects the strengths of the communities they serve. And so this model is something that really needs to inform syndemic sensitive health, syndemic sensitive emergency preparedness, syndemic sensitive neighborhoods and planning. Because communities do have the local expertise, the knowledge, the relationships, the localized data, and the trust that are needed. And you've probably read a little bit about the importance of that trust now that we're starting to get into the period of vaccination and want to make sure that people feel safe coming to receive vaccines. These are the foundations of those local feedback loops that I was telling you about earlier in the presentation, that in a complex adaptive system, and they are otherwise not accessible to large institutions and mainstream health systems. And that's why we have lagged behind in COVID response over and over again, because those one size fits all or those approaches that prioritize some populations over others are not going to be effective in dealing with a health emergency like COVID-19. And later on, I'll pop into the chat box 2 recent studies from BMJ Global Health that have really showed that countries that have strong community health systems and strong community engagement have fared better during COVID-19 and other health emergencies. And the image on the right here is of the model that community health centers in Ontario follow. And the thing I want to highlight for you amongst this, and you can check it out on their website, is that they're community governed. So they're really run by and for the people they serve. And they help to build the capacity, but also tap the existing capacity of these neighborhoods, which actually have a lot of strengths that have not been given the opportunity to thrive. Here's an image from the World Health Organization that also advocates for this comprehensive model of primary healthcare all over the world. It's a way to make sure that at the very local level, communities can participate in multi-sectoral policy and action, that they are empowered as individuals and as communities, and that primary care is well integrated with public health as at the core of integrated health services. And this is in some ways a new idea for people in public health who often think at a higher scale, at the scale of the city, for example, or the scale of the province or the country, and who have tended to think that population level impacts can only happen with population level actions or big P policy change. Now, of course, those are important, and we need to do things like build affordable housing, enough affordable housing for everyone, and make policy changes that address the root causes causes of inequities. But we can also have significant population health impacts by aggregating the work that we do at the individual and neighborhood level. And that this component of the contribution of communities, its time really has come. And the WHO has called on countries all around the world to contribute 1% more of their GDP toward this effort. So one way that community health centers have been very effective in mobilizing the capacity of communities is through social prescribing. And at its core, social prescribing is a way to use a healthcare visit to reconnect people with their communities, to help them tap into their own capacities and the capacities of their communities, and also to address their social determinants of health. So it's a way to provide a supported referral to community and social services, either formal or informal, and to track the benefits or the impacts or the journey and on the client themselves and on the practice of the clinicians. And so there's a constant, very small local feedback loop under which clinicians and health promoters and clients are receiving information and data about how things are going so they can iterate and continue to change things on the fly. And you can see from this example that there are many different kinds of social prescriptions that might be offered to someone should they so choose. You know, going fishing, playing music, taking a break and dancing, accessing food, being part of a community kitchen. The list could be endless. So I want to tell you a couple of examples of how this has happened in that northwest corner of Toronto during the time of COVID-19. So there are two community health centers that have been particularly active in that neighborhood, in those neighborhoods. And they are Rexdale Community Health Center and Black Creek Community Health Center. And you can look them up on Google if you want to find out more about them and more about how they work using staff, governors, and leadership from by and for the community. And so the pictures here show a pop-up COVID testing site, a repurposed TTC vehicle, a bus, and a local DJ playing music to help people feel comfortable, safe, and welcome at this pop-up testing site. And what's significant about this testing site is that it happened very early in the summer when the community health centers really hadn't received much, if any, funding from the province, from public health, or from the federal government. They made this happen because they knew that their communities were facing significant barriers to accessing mainstream COVID-19 testing sites. Those barriers might be transportation, it might be 2 bus rides away to the big local hospital. They could be economic, not being able to take time off work without paid sick days to go take a test. Or they might be related to systemic racism and a reluctance to go to an institution that has discriminated against you or your community or both in the past. So all of those barriers existed. So the community health centers stepped up and created their own pop-up testing sites at their own cost for the most part. And they followed these principles. They made sure they were using communication that was culturally relevant, it was clear, and it was trusted by the community. They used co-design principles with the community and with clients to make sure that they were offering the kinds of services that people actually wanted and needed and would use, and that they were located in place that felt safe for the community to access. Sometimes that might even be something as simple as making sure it was on one side of the road and not the other. That there was collaboration across health and social silos. And this was important because one thing that they were doing was they were doing social prescribing referrals right then and there at the COVID-19 testing site. In other words, you didn't just get the swab for COVID and go home, you were screened for your social needs. Are you socially isolated and in need of connection? Are you food insecure and in need of food? Are you income insecure and in need of support to maintain your employment, and so on? And supported referrals and wraparound supports would be made available to you right then and there. And it's that level of trust, collaboration, and support across agencies working together that is needed to really meet the need. The principles here also include consumer governance of sociodemographic and race-based data. And that just means, first of all, we weren't even collecting sociodemographic and race-based data early on in the pandemic. So we really couldn't say for sure which communities were more affected than others. And we weren't sharing that at the neighborhood level in aggregate. And so, there was a big fight here in Ontario to make sure that happened. And we did make it happen starting at the local municipal level. But then the governance is also a critical component of that. And learning from the governance principles that First Nations, Inuit, and Métis people have brought to bear on their health data, ensuring that the local communities, Black, Indigenous, and people of color, and other communities affected by COVID in disproportionate ways are participating in and leading the governance of and the use of their own data. And finally, and I think very significantly, a contribution of government resources to community and to consumers or to clients. And that is something that did happen over time. So as I mentioned, they started off this work without being funded, but the work got the attention of Toronto Public Health and became funded under a high priorities community strategy. And that in turn got the attention of the provincial government, which funded a similar strategy in other communities, and including Toronto, but also more broadly, that were at high risk from the pandemic. And then in turn, this has gotten the attention of the Public Health Agency of Canada, where I'm now working to help envision a community-led component in the future of public health, in the future of our public health emergency preparedness. And so it's that proof of concept at the local level that has really enabled this to happen. The other thing that's happened is that other organizations, not just community health centers, have taken this on as well. And so we've seen an explosion of interest in programs that combat social isolation and loneliness, for example, recognizing how many of us are isolated at home, and in particular for seniors who are more strictly isolated and may have already had pre-existing isolation and other health risks. And we know that social isolation is a health risk on par with smoking and heart disease. It's very significant in its impact on our bodies, on our mental and physical health. And so it is a health risk that needs to be addressed. We've also seen acute care systems and mainstream healthcare starting to take this on as well. And so the story here is about UHN, the University Health Network, which is Canada's largest hospital system, working together with community health agencies and food security organizations to do a mobile health clinic that helps meet people's material health needs, such as food, housing, tax and income support, and so on. And so the principles underpinning this work, again, are related to action at the neighborhood scale, reducing contacts through public health measures at as local a scale as possible, releasing those neighborhood level data that I mentioned to guide decisions and to ensure accountability, representing the people who are most affected at decision-making tables. And this is one that I've worked quite hard on this year to help remind decision makers that not only are these communities not simply communities with deficits, but they're communities with significant strength and expertise. And there are many people who are whose voices and expertise need to be included at these decision-making tables if we're going to learn and if we're going to be effective in containing health risk. And we need to resource community, I've mentioned that before, to lead those trusted and strengths-based local responses. And we're not totally there yet. We're there with a few of these COVID-related measures. But in my view, the future of healthy and well-planned communities is going to be in tapping and maintaining and sustaining the capacity that exists in those communities. So social prescribing, let me tell you a little bit more about how it actually works. And one of the key things is the cognitive shift in healthcare providers from what's the matter with you to what matters to you. And in asking that question about the material, but also social and spiritual components of health and well-being, we're able to better support people using principles of health promotion that really are about supporting people and communities in their ability to take better control over the conditions for their own health and well-being. So it begins with a client, an individual with social and medical needs, yes, but also with interests, strengths, and gifts. And this person might be encountering the healthcare system in any number of ways, that any door could and should be the right door for social prescribing. In our pilot project, it was in primary care. So in a visit with a doctor or nurse practitioner, for example, something came up that was beyond the clinical expertise or capacity of the prescriber. It might have been that this person was having many, many repeat visits at great expense to the health system, but for issues that were more about loneliness than about any clinical need. It might be that the person required access to more secure and stable housing. It might be that they needed a community of support around them because of a need for a harm reduction approach to substance use, and so on. The prescriber doesn't need to know what the solution is. They just need, or even necessarily that much about what the problem is. Just identify that there's someone who might benefit from a social prescription. So in turn, the clinician, the prescriber, connects that person to a social prescribing navigator. And that's the person whose job it is to really take the time to walk alongside that client, to listen, and to find out what's important to that person, to help them rediscover their strengths, interests, needs, and what would support their well-being, and then to walk alongside them and support them in taking action on that social prescription. So, for some people, it might be as simple as writing down a prescription on a pad, but for the vast majority of people, and in particular, the people facing significant social complexity that are the clients of community health centers, that hand-in-hand support is going to be very important. So the individual will be connected to those social and community supports, and the link worker might even go along with them for the first few times or do other things that help ensure that they feel supported and able to continue to follow through on their social prescription. One of the most important findings that we had is that people who were enabled and empowered to give back, to more deeply engage, to co-create solutions, and to become leaders or volunteers reported the greatest benefits to their own health and well-being. And it's again that cognitive shift from seeing yourself as someone with a deficit or your community as one with deficits to recognizing the strengths and what you have to offer. Many people don't want to be helped, but all of us want to help. And this is something that we can empower, support, and help to thrive under social prescribing. And then the other key component is data tracking. We track the client journey, we follow up, and we keep trying to improve through a learning health system approach. So the community health centers have a shared electronic medical record, for example, and we can track how people are doing, how their self-reported loneliness has changed or not throughout the life of their participation in the project, how their overall health and well-being has changed, how their engagement with community has changed, and so on. And it's this feedback that has been particularly impactful for prescribers. So we might have some prescribers who were initially hesitant, for example, that this would have much benefit for their clients, or that maybe they thought it would take up even more of their time as they tried to manage something new. But what we learned through the pilot was that for the most part, clients reduced their reliance on the more expensive and less appropriate clinical biomedical services as they moved upstream, and it found better solutions or complementary solutions in many cases to the long-term health conditions that they were facing. And so prescribers increasingly supported the project over time because they were participating in that local feedback through a learning health system. So here are some of the findings of our work in 11 different community health centers across Ontario in the pre-COVID period. So we worked in urban areas like Toronto, but we also worked in the remote north. We worked in Francophone communities. We worked in rural communities, many different kinds of places who all use social prescribing in slightly different ways. But across the board, we saw dramatic impacts. A whopping 49% decrease in loneliness, which is such an important indicator of the health and well-being of individuals and communities. A 12% improvement in mental health, a 19% increase in participation in social activities. These are dramatic results that are on par with or superior to many more biomedical interventions. And so this leads us to believe that social prescribing is something that we need to continue exploring and scaling. Here's a bit of the data about those health providers. As I mentioned, they reported that social prescribing improved their clients' health and well-being over time and reduced the number of repeat visits by clients. Now, there will be always a small cohort of clients for whom visits actually increase, and that's a sign that they're probably taking better care of their health, managing chronic conditions like diabetes, for example, where maybe they weren't attending their family practice enough. But for the vast majority, there's been a big decrease in the number of visits for clinical care. So in the time of COVID, we have actually found that the pivot to virtual programming, the pivot to drop-offs of essentials and food, medication, and other supports, the pivots to telephone trees and other ways to reach people have actually been remarkably effective. And so we are continuing to build the evidence based on what's happened over the last year, but we've managed to reach many different kinds of people who were not physically attending programming at the center, who now can access services from home, people with mobility challenges, for example, people who were not aware of the programs and that sort of thing. So here's what the program participants say. This program said, in fact, you identify the different needs in your local community and then create the solutions you need. It was the philosophy that we are creating the solution for each other. That really spoke to me, and it's given back to me so much. And for me, this really encapsulates the significance of social prescribing in the individual lives of people and how transformative it's really been. In turn, the work of community level agencies and the agency of communities, the power in communities that they have to understand and meet their own needs, given enough resourcing and support, has become increasingly recognized. So Toronto came up with its COVID-19 Equity Action Plan that we passed at the Board of Health, that the community health centers have worked together to think through a healthy recovery that really works for everyone at that community scale. And as I've mentioned, the Chief Public Health Officer of Canada and the Public Health Agency of Canada are increasingly thinking about the role of communities and local resilience in equity approaches to not just COVID, but the future of public health and our future preparedness for other emergencies. So a few comments about what you might be able to do next as people involved with planning, to really think about syndemic sensitivity, that intersection between a new health emergency and pre-existing health conditions that have social and economic roots, by resourcing this kind of strength-based local approach to community capacity. You need to be thinking about how to build connected communities, including things like social prescribing, to integrate the services that are already there in the community, but also perhaps reach out to virtual services offered further afield, to really think about addressing social needs and social determinants, connecting people within communities, and scaling up the work of health promotion that, as I've mentioned, is really about helping people to take more control over their own health environments and health conditions. And then I think also very importantly is to build that responsive data and feedback and transparency into a learning systems approach, because we know that communities have expertise that institutions otherwise can't access, but very much need. And we need to be able to share that data in locally appropriate ways so that we can continue to build on our capacity to take action. So I have a couple of key questions for you to think about if this is the kind of work that you think you are doing now or would like to be doing in future. Making sure, do you have the data you need to act at the neighborhood scale? You should be collecting and using disaggregated sociodemographic and race-based data. And Canada is further behind in the journey on this than some other countries, but we are on that journey now. And the community health centers have been collecting and using these data very successfully for many years, and have some great examples of how they've been able to tailor supports and services to those communities who were identified as needing them. So for example, recognizing that Black and racialized women were not receiving cervical cancer screening at the same rate as white women. By targeting supports to those communities, that health disparity and gap was managed to be significantly reduced in the communities where it was most needed. We need to be releasing those neighborhood level data, like I've mentioned, to guide decisions. And that was another big piece of advocacy work at the Toronto Board of Health. And you need to use that real-time feedback, a learning system, to help iterative and hyper-local decision-making. And you need to make sure that the community-based resources are there to act at the community level. So I've talked a lot about community health centers. They're not the only community agencies that can do this. They're not located in every community across Canada that needs them. But they are a good example of how you can make a difference during COVID-19 and during other emergencies. But because of this model that really focuses on the distinctions-based approach to health and well-being and strengths-based approach. So from my perspective, there's an urgent need to scale up the CHCs as a first line of public health capacity, but also to resource other kinds of community agencies with similar roles to work together to meet the needs in their communities where they are. And then lastly, do you have the governance and the structures you need to act at that neighborhood scale? The trust of marginalized communities will be very valuable in future and is something that we should not dismiss in terms of its importance to our ability to work together, to collaborate across difference and to build more cohesive and equitable societies. We want to be using social prescribing to link healthcare and social determinants of health action at local scales and broader scales, and to track the benefits to health systems so that we can get more decision makers on board. And then finally, as I've mentioned, the governance by and for the most affected communities is critical to the success of this kind of work. So this is my last slide. I just want to reiterate to you that community health and social prescribing are vital, not just for health and well-being and connectedness, and the theme of your conference around being connected. They're also essential to our preparedness for health emergencies, that connectedness and that ability to take action at the local level is what we're going to need going forward. And so those are our syndemic sensitive future horizons for planning that helps build connection. And I'd be really happy to have a conversation with you about this starting now. Thank you so much.
Thank you very much, Kate, for that wonderful lecture. We do have some questions coming in, so I'll just start with the first one in the chat here. But during the pandemic, many people have had to pick between that social connectedness and mental wellness and physical health. So how do you think that we can bridge this gap so that people can stay connected while staying safe, as we're starting to see the emergence of Zoom fatigue or people feeling burnt out from virtual?
Yes. So what we found in the work of social prescribing is that you don't need to be feeling particularly extroverted to have social connection and social connectedness in your community. And because of our findings around volunteering and giving back as being so significant to one's health and well-being, I really recommend that as a place to start. When you're tired of Zoom, when you've maxed out your connections with your sort of inner circle of family and friends, that getting out and doing something that's of service, even if it's something not particularly interactive with others, is going to make you feel better. A community cleanup, for example, in your neighborhood, going for a walk in nature. One of the things that's been lost in terms of community connection this year is what I call the weak ties, the kinds of relationships you have with people in your life who aren't your immediate family or coworkers or friends, but you see around, your neighbors that are a little further off, the person who's always behind you in line at the coffee shop, the bus driver, people that you sort of know. Many of those kinds of weak tie relationships have been lost this year. And so just getting out in the neighborhood, just being around other people can help you feel and reconnect to that sense of belonging. And so you don't have to be doing it over Zoom. There are many other ways to stay connected with that broader group and reap the benefits. And, we know being outside in nature, physical activity, healthy eating. All those things are healthy for us and help us to keep doing that kind of work of connecting to one another. So small steps are completely okay, especially at this time when we're getting so tired.
For sure. I did have a question based on your lecture. A couple of days ago, we had a panel on community engagement where they really focused on two questions with of how you engage a community and then why you engage that community. And you had mentioned that in order to harness that local expertise, that strong community engagement is important. And I just was wondering if you could speak to how that happened in Toronto during the pandemic.
Yeah, I think that so oftentimes here in Toronto, community engagement for planning purposes is very well intentioned, but ends up being a bit of a tick box exercise. It can be like pulling teeth to get people to come out to an event and talk about how they feel about about what's happening in their neighborhoods and in their communities. That's why community-led engagement is so important. When the work is happening by and for the communities who are most affected on matters that are important to them, and that they are in the driver's seat in terms of how engagement happens, when it happens, what it's about, that's when you start to see that more impactful and transformative impact. And so that's where I think the role of leadership in community agencies is so important, because these are the folks who are from the communities, but also have the experience and expertise to interface with other levels of government, with other agencies, and so on. And so oftentimes that community engagement can happen at the level of those workers and those agencies, and that is an important component of the planning process. And so that's where I think that the community, the sense of community leadership over consultation is going to be really important going forward. So one thing that we saw, for example, was even early on in the COVID testing sites, some money and resources did go to community health centers for some of those pop-up sites, but the decision-making still rested with the hospital. And what happened in that case was they just didn't have the expertise to know things about how to talk to the community, how to do good engagement, how to think about barriers, where to locate services, why it might be important or even possible to do social screening. When the decision-making is too far from the community level, there are just way too many barriers and inexperience. And I think my experience on decision-making tables throughout COVID is that the social isolation of decision makers themselves has been a big barrier. In other words, well-off white people at home have a harder time thinking about people in communities that are having a completely different experience from their own, the longer they're spending time just working from their home offices, and not having, like I said, those weak tie interactions with the diverse communities around them that make up the life of the city. And so I actually think that's a significant issue. And so that's another reason why decision-making as close to the community as possible is so important, because that's where the knowledge is.
For sure, yeah. So building on that, there was a question around how do we go about building that initial connection with communities that have never been engaged before? Or I'd like to add to that, who have had really negative experiences with more of tokenistic engagement.
Yeah, okay, so that's a great question. There are not that many communities who've never been engaged, I don't think. They're just engaged with somebody who isn't you. And so I think the thing is, again, there's always community influence, leadership, capacity. And so part of your task is to find out who that is. Who are the influencers in the community? Perhaps it's the faith community. Perhaps it's an informal settlement of people living who've been excluded from housing. Perhaps it's the harm reduction worker who knows everybody in in the park. Like there's always going to be someone or multiple someones who take leadership in a community setting. And so, taking the time that's necessary to tap into existing structures of leadership and capacity in those communities that might look really different from what you expect is one important way to do that. And that's why I think the strength of those community agencies is so important, because they do have the experience and the know-how on how to do that. And that's not to say that they have always gotten it right, but if they're following a model where they're using both community governance, anti-oppression and health equity and data, they've made that commitment to continuing to try to iterate and to keep trying to get it right. And so that level of partnership is I think should be an absolute requirement for people to do this work. And indeed, that's what happened here in Toronto, where, over time, the Toronto Public Health went from trying to do a lot of these things themselves without the real knowledge at the local level to funding the community agencies directly to do the work and partnering with them enough to make sure that they were learning from it. So they weren't just shoveling money and then leaving it, but partnering together, learning from that experience, continuing to build partnerships, collaborations, and capacity, but trusting community agencies to be the ones to have the expertise to take leadership. And I think we will be continuing to learn from the benefits of that approach for a long time to come. And so I encourage people to look up that Toronto Health Equity Action Plan, the first citywide health equity action plan in our country. And to learn more about that, and then some more recent investments at the community scale, including investments in a Black COVID-19 health strategy led by and for Black communities. So I'll stop there, but I think that's the level of partnering with those people who have expertise in the communities, and they are always present. It will go a long way.
For sure, yeah, we definitely had, and a couple days ago we had some librarians talk about connecting with their communities and how they're often like the only places left in communities where people can go for free. And you mentioned in your lecture that really strong importance of the informal and formal social services and places that exist in the social prescribing of it. So that point that you made is very...
So several of our social prescribing pilots do have connections with libraries. Rexdale, for example, which is a very spread out community, has library services right within its health center hub. And the community health centers are similar to libraries in the sense of creating that open and welcoming space of belonging for anybody. And so, yes, the libraries have done an excellent job of thinking about their role as third spaces and community connectors. And we want to be able to maintain that going forward.
For sure. So we have another question here from the attendees. So as planners, our work is often based around the built form. What role do you think things like placemaking can play in healthy communities if done properly?
So great question. I happen to sit on the board of 880 Cities, which is a small nonprofit organization that works in Canada and around the world on that exact question. And the organization itself is really grappling with how to make sure that the work they're doing is equitable and learning a lot from the COVID-19 experience. And so one example here in Toronto was the use of quiet streets. So last spring during the pandemic, the city established several quiet streets in which they put in temporary traffic calming measures, pylons basically, periodically along the streets. And my own street was one of them actually. And sure enough, they seem to be in slightly higher income or middle income neighborhoods. And so there were some unintended consequences of that work, which we're learning from now. And one of them was that in some neighborhoods, the presence of the quiet street actually emboldened people to act out in racist ways. To say, the sign here says local traffic only, and you look like you don't belong here. So even something that was well-intentioned, that was supposed to be a way to help people be outside safely in a time of pandemic, can have these unintended consequences when it does not happen with community engagement and community leadership. And, I think in some ways that it's quite understandable that it happened so quickly in a time of emergency, in a time of COVID. But now we've learned from that, and we need to think about how we would do this kind of work going forward to incorporate the benefits, but also to learn from those unintended negative consequences. And so that's part of the learning that 880 Cities and the City of Toronto have done together about the built form. So again, even something small like putting up pylons, and even the institutional look of pylons is very unwelcoming for some people in some communities. All of that stuff needs to be considered. We've learned that in our harm reduction facilities, in the supervised consumption sites, that one of the sites in South Riverdale on the east side of Toronto, the walls were painted an institutional shade of yellow. And the people who were gathering in the site felt very alienated by that because it reminded them of prison and of being in correctional facilities, and so had to be repainted. So sometimes it's details that if you don't ask, you won't know. And so we need to learn how to do that work and to collaborate and to do that together. So I hope that wasn't too long-winded an answer, but we continue to learn about that and want to make sure that we are doing the equity work, learning from what we did under emergency circumstances in COVID. And what I have experienced this year is that in a time of emergency, we really don't have much choice but to rely on the pre-existing systems that we have. And we know that those pre-existing systems are not equitable. And so, of course, there will be inequitable impacts. So what we need to do now is build what we can such that our muscle memory that gets engaged in an emergency is doing something that's more equitable, is doing something that's more sustainable, that's more fair. And we are not there yet. And that's our task post-COVID, is to build some of this in by design.
For sure, and it definitely leads into a question that I had from the beginning of your lecture, where you showed how even in a pre-COVID era, we had these inequities across Toronto, and how the pandemic really just exacerbated these and just exacerbated the barriers to health access. So I guess my question is what impacts from this do you see that COVID-19 has on future health access? And is it more of a positive or is it negative? Has it?
I hope that it'll be positive. I'm an optimist despite everything. And my sense is that we have a very limited window in which to act, that the flow of funds and spending and learning from COVID will only last for a year or two. And then we'll be in a period of austerity where we try to cope with the amount of spending that's happened to keep us afloat during this crisis. So we have to take rapid action. So, what I would like to see is a huge expansion of CHCs across the country, or a huge expansion of resources going into similar types of organizations at the community level. I think that's in the realm of possibility, given the federal interest. And I never would have said that a year ago. Even provincially, we were struggling to get enough base funding to keep the lights on in many of these organizations. And it could go either way. It's really hard to know. But if we take rapid action, there is a window that's open now for taking that kind of action. And if we think about it in terms of, this is a way to, we've demonstrated that there are system savings. We've demonstrated that there are certain impacts that will never, ever be mitigated unless we do take this approach. And we've demonstrated that this is necessary for emergency preparedness. So, trying to marshal all the arguments that we can think of to help support this, so that we do have, community level resilience going forward. So I'm optimistic in the short term, and in the longer term, it's less so. So that's why I'm feeling very excited about moving to doing a bit of work at that federal level, because that's where I see the most momentum at the moment.
For sure. So just another question here from one of the attendees. You've talked a lot about the importance of community knowledge, and I found in my own work that often local knowledge and locals having a personal stake in projects and initiatives often create greater longevity and sustainability in these projects. Mm-hmm. Have you seen evidence of this in social prescribing, that it may be more sustainable than other health initiatives in these communities?
Mm-hmm. Absolutely. And the example that comes to mind is from Temiskaming in Northern Ontario, where the social prescribing work has focused on the minority Francophone population in the small community of New Liskeard, and has created a new sense of belonging for a group that's only about 15% of that small community, the French speakers. And they have sort of found new cultural life because of this work of social prescribing, making sure that they drive one another to health appointments, get together to sing cultural songs, do art together, give caregivers a respite. And caregiving has really been shown to be a significant determinant of health. Caregivers have poorer health outcomes than everybody else because they're busy caregiving and they're not supported. And certainly those of us who have been caring for children, particularly women, have been really feeling that this year. I have 3 kids of my own and have tried to manage it all. So yes, absolutely. In Temiskaming, I see this social prescribing initiative as something that's been quite transformative in their understanding of what health services are even for and what they're about, and that there's that sense of ownership in the local community over what happens there. And that's in a place where there are very few government services. And so it really is incumbent upon people to create their own. And that's what they've done. And actually, I can, later on, I'll send you a link, Victoria, because there's a great little video from Temiskaming that shows what I mean.
Perfect. So just building on that question, the 2 fields of public health and planning have kind of diverged from each other as fields of thought, and are only recently kind of coming back together as seen as being complementary. So as we transition into our careers as planners, how do you see the role of planners assist in implementing and working alongside health promoters and health social prescribers in building healthy, more resilient communities?
Yeah, I think there has been a huge growth in understanding within public health of the importance of planning and of the built form on, but also social planning on people's health outcomes. And so in the past, I worked with Toronto Public Health on a number of active transportation projects, and so saw that there were some mutual interests, but also some significant barriers to collaboration in terms of what outcomes were most important to people, what measures people were being held to, how much freedom they felt that they had in innovating in their work. All those different kinds of things, and then different approaches and orientations to community engagement. And so it was, from my experience, I gained a lot of empathy for the challenges that planners face in the work that they do. One of the projects I worked on was the Bloor Street bike lane, and it didn't come to fruition until 7 years after my role in it. It was a long process. It involved tons of work, many studies, getting different kinds of communities on board, from the business community to the commuters and so on. And so the time scales are sometimes quite different. That in healthcare, we want to take more immediate action, and you'll see community health centers wanting to roll up their sleeves and do something immediately. And the time scale for making change in the built environment or doing social planning is sometimes much longer. So there are ongoing conversations that still need to happen to help bridge those disciplines, but there's a clear recognition on both within both fields of the health dimensions of planning and how important it is to build that collaboration. And one thing that I think public health isn't particularly skilled at, and that they should be, is putting themselves in the shoes of the people with whom they need to collaborate. In other words, transportation planners might not be all that interested in demonstrating a health outcome. They might be more interested in showing efficiency of movement or something else. And so really thinking about, how are you helping to solve the problem of the person on the other side of your relationship? How are you supporting that work? And as planners, I think the same question would apply, right? If you want to work together with public health or with primary healthcare, what problem are you helping them to solve? Or what new thing are you helping them to build that they might see as in their interest? And that can be quite hard for people to really do that work across disciplines. But for me, it's been my life's work to do government relations and advocacy that helps us bridge those differences and those barriers. And sometimes it means using language that people aren't always that comfortable with. So the term social prescribing, for example, isn't necessarily the favorite of many health advocates and people working in social justice. It might seem too biomedical. It might seem too healthcare systems focused and so on. And they're right. But this is the term that has captured the attention of healthcare decision makers and policy decision makers and funders. And so despite the challenges of the term, it's the one that has helped people recognize and see work that has been going on under their noses for many years under a different name. But by tracking it, by giving it a new name, we're reaching new audiences and new people and building bridges. And so that, from my perspective, is important. It might become important in your work too, to be willing to try to do that knowledge translation, to do that interpretation across difference, across class, across race, across gender, across power, across disciplines, across levels of government, you name it. Be willing to take the more humble position in order to help in the service of the outcomes that you think are most important. I think that's something that I've really learned over the years of doing this work, and has been remarkably effective in trying to make sure that we continue moving forward and get things done.
For sure. And you had mentioned 3 key takeaways as planners, with one of them being to help build better responsive data and transparency with communities. I was wondering if you could speak to what this would look like, as sometimes data isn't always transparent, especially when new programs or plans are implemented.
My feeling is that the default orientation to data in Canadian governance is secrecy. It's extremely difficult for journalists to access information, for example, about any government service. Here in Ontario, the mandate letters to cabinet ministers were never even released. We don't know what their agendas are. Trying to make sure that we not just collect and use, but also share data during the pandemic has been an ongoing fight. We still don't share data around workplace outbreaks, for example, at the provincial level, despite the fact that we know that in this stage of the pandemic, this is a workplace pandemic. In Peel region, for example, manufacturing industry has been the site of huge amounts of transmission, but they don't release the data. We've worked really hard to advocate at the board level at Toronto Board of Health to open this up and to make sure that it does happen. So I'm a huge advocate for transparency, and that doesn't necessarily earn me a lot of friends in government. And so it will require a cultural shift. And that's where I think you, as emerging career planners, you need to think about where you want your work to sit on that spectrum. And from my perspective, there are very few downsides to being very transparent about the data and about how you're making decisions, and many downsides to keeping it secret. But as I've said, that is not the default orientation in Canadian governance at the moment. And so we'll continue to face challenges. And so that's one reason why I think it's so important that we have public members of boards. So it's not every board of health in Ontario has public members like me. I'm not an elected official, I'm a regular person on the board. But we do, and a few others do. And in Hamilton, they're going to be, a group of activists is going to be making a recommendation on Monday to open up their board of health to include public members, for example. It's all by way of being able to push governments to do what's right, to do what's necessary for our communities, and to be a bit of that voice of community capacity. And we've been quite successful here in Toronto at pushing public health to do the right thing. And so, yeah, that was a long-winded way of answering your question, but I hope it does. That's, the default, the principle of transparency is the one that I would bank on.
No, it definitely did answer it. For me, it's something that I've thought about frequently as I've done research and things like that in my master's program. So another question here from one of the attendees is, has Toronto implemented any community-based programs that you're aware of to support and increase healthy food access in marginalized communities during the pandemic? Or do you think there's a gap? And if so, how do we bridge that gap? I'm curious to hear your thoughts from a public health perspective and how we can better support healthy food access in marginalized communities.
So definitely that there have been initiatives. I don't know for sure that they have been done by the city per se, but that one social prescribing program led by the University Health Network that I mentioned, where I showed the picture, that is a partnership with Food Share, which is a food security, food justice organization, very much focused on making sure that people who are attending to the hospital for COVID and for other social needs are provided with food. So they receive good food boxes, for example. All the community health centers do this as well, delivering either hot meals or groceries or those kinds of things, or supporting access to food banks, although we know that that's not, that's not the same thing as real food security, but in the time of crisis, it's food access. And so, yes, it is happening. It may also be happening at the city level because every division of the city has been enlisted to take action on any equity matters that remotely touch what they're doing in the time of COVID, and they've done remarkably well under the circumstances. But food access and mental health are two that the city doesn't actually have a lot of direct responsibility for. And so they've tried to do what they can to support this, recognizing the need and recognizing the capacity they have, being the closest level of government to community. But there are still significant limits to what they can do. So social prescribing is one way that we can do that, some of that work of better connecting and tapping into the much larger resources that are available in the health system, like through the hospital, to make those referrals and connections. So it's not a solution, but again, it's something that, what they say in the UHN program is that it gives people breathing room while we try to figure out some of the bigger issues.
That definitely reflects some of the conversations that we had in our food access panel on Monday around how access to food isn't just about food, but it's how one intersects with their life and their built form and their environment and access to transportation.
Before you go on, Victoria, just on that note, one of the most interesting referrals that I've seen too is in the Black Creek community with the Black Creek Community Health Center. They actually have navigators located right within the emergency department of the hospital, Humber River Regional Hospital. They're employed by the Community Health Center and can make social referrals and divert people away from ER who don't necessarily need to be there in the first place. And they can refer people to many different things. And one of the best ones in that area is the Black Creek Community Farm, which is an explicitly anti-racist urban agriculture project where people can get involved in farming and being outdoors and food growing and building that sort of those domains of food sovereignty, which are the more long-term solutions to these kinds of crises. So even if social prescribing itself isn't always the immediate response, it can connect people to some of these really interesting long-term and big projects.
I don't know if anybody else from the attendees had any additional questions if they wanted to kind of think some of those things through. I'm just reading through some of my notes here from the food access one as well, where we talked a lot about figuring out ways to like relieve this pressure, as a lot of times in planning, plans are created with good intentions, but they can often end up being shelved in offices, and it can take a long time for things to be implemented and followed through. So I guess in your work alongside the social prescribing, have you seen any promising interventions that have come out of planning?
Not through the work of social prescribing with community health centers per se, although if you ask people working in community health centers, they would definitely say yes, because they would be well connected. Actually, one that comes to mind that was a bit of collaboration was using the Canadian Index of Wellbeing in Ottawa to get a sense from communities about what they felt was important for their own well-being. And that work culminated in the production of a low-income bus pass for people living in Ottawa. And so it was a bit of a collaboration between planners and municipal government and the community health centers working together with community. That was a few years ago though. I think that in general, the time horizons tend to be, like I said, a little bit different, and the community health centers are often operating in emergency mode, particularly during COVID, but all the time really for people who are facing major social complexity in their lives. And so I think they definitely have a mandate to do advocacy, community development, and intersectoral action. And so they would be part of those conversations, broadly speaking. I think as planners, you need to be at the health planning tables. Here in Ontario, we have the Ontario health teams, which call health services organizations to come together at a local level to make planning decisions together rather than having outcomes prescribed by government. They're supposed to be working together. You should be at those tables. You should be talking about why planning is a component of health, and why health services and the built form need to align well together and that sort of thing. So it would be good, I think, to see even more of those collaborations happening at the local level. Certainly the CHCs have a lot of experience in collaborating with many different folks and would welcome that, but I'm not actually aware of lots of other examples.
So what is something you see being done successfully elsewhere that you'd like to see be taken up more widely in Canadian communities?
Can I say social prescribing? I mean, I really think that's the one that needs to grow. We've done it well in some health centers in Ontario, but we don't have broad funding for it. And likewise, community health. That community health. Countries in Asia, for example, and in Africa that have strong community health workers and community health programs, along with experience with infectious disease, have actually fared much better in COVID-19 because they already have these very local structures of support. So I would like to see us do what they've done, which is focus on prevention and spend a lot less money on acute care and spend more of that money on things like planning, on things like community level action, on the social determinants of health that we know make up more than 80% of the impact on our health and well-being, our health outcomes, and far less money on the 20% that happens in acute care.
And I think that definitely relates to what you talked about in your lecture about asking that question, what matters to you? And you related that to your importance of that cognitive shift that needs to take place. And I'm wondering if you could speak to how that cognitive shift might play out at the federal level, as I know you've switched roles from the Alliance.
Yeah. Again, I think because the case that I think needs to be made is that we actually can't succeed without it. We can't be sustainable without it. When another emergency happens, or even in the absence of another emergency, the current life that we live is not equitable. It's not sustainable. It's not healthy for us. And it's very expensive to maintain. And so none of that makes any sense. And so if you can make an argument, for me, I'll be making the science-based argument to those scientists around, this is just the sort of the right thing to do to make sure that we have an efficient and effective system. There is knowledge here and capacity that we're not using, and that we won't succeed without. And so for me, that's the argument that I'm hoping will work. But there will be lots of other arguments to be made around the economies of it, and the broader impacts and so on. And so that's kind of where I see this as this is a quite logical response to what needs to happen. And we can make, in addition to our deeply felt work on advocacy and justice, which has been very emotional this year, very challenging, has been quite disheartening at times. We can also make this very dispassionate case for what needs to be done just based on the evidence. And it's hard when, even in the face of evidence, the right thing still doesn't happen. And that's where we need to mobilize together to address the power dynamics that are creating that injustice. And so that's the big question mark about what kind of evidence will really convince people to make the right decision going forward. And I think that remains to be seen over the next 12 to 24 months.
For sure, yeah. I don't know if Dr. Wren Thomas had any questions at all.
I don't have a question, but it just strikes me that some of the things that you're saying, that you're talking about here, like the social prescribing does kind of remind me of navigator programs for people who are experiencing homelessness. That the idea is to get them in touch with services that are that they need, that they may not know about or may not be able to access, for example, if they don't have a permanent address and that kind of thing, or they might not know they can access health services. So it does kind of remind, like, some of
Uh-oh, am I the only one can anyone hear me?
believe there was a brief power outage here in Halifax.
Oh my gosh.
Yeah, mine just flickered and came back on. So I guess that's where
Okay.
everyone went. Yeah, it's pretty nasty here today.
Whoa. Okay. All right. My brother
Yeah.
was living there during Hurricane Juan. I remember that. Should I stay?
Yeah, I mean, my power is back on. It just flickered, so it might
Okay.
just be a temporary thing.
Okay. I'll stay.
Okay, I'm just conversing with my classmates here to see what's going on.
Okay, I'm gonna turn off my video and stuff for until you're ready to check in again. Okay.
Okay. I was told.
Oh.
All right. 1 second. The last question. Okay. So Victoria just said the last question that she had was where do we go from here with I guess with everything. What's the big takeaway?
Okay. And can folks hear me now?
Would people just message in the chat and say y'all can hear?
Okay. Yep. Thank you, Natasha. So where do we go from here? We collaborate, we work together, and we have courage in reaching across boundaries. And we have the courage to speak up when we are facing kind of those challenges around transparency, around inclusion, belonging, and governance. And that can be quite challenging for people at the beginning of their careers to address the power dynamics. But, you know, if you're coming in as a cohort of young people and early career professionals who have these values and this evidence at your back, I think you will be really strongly positioned to create newer and more equitable and more open ways of doing things that really address the social determinants of our well-being and our equity and our sustainability going forward. And so I really encourage you to keep that up as you enter into your careers, and don't hesitate to reach out to mentors in your early careers. Particularly if you are young women, or if you're people from marginalized communities, you know, we all get advice to sort of to be polite. There's a Canadian poly test that makes it difficult for us to speak to power, that creates bureaucratic barriers. Like, try not to get into that. And, you know, people, you know, when they say step aside and let other people have their moment, those people are stepping aside for you. You have that community expertise, that knowledge, that power that that our institutions need and don't have. And so do not hesitate to use your voice early and often, because we really need to hear it.
Great. Thank you so much. So I just heard from the rest of our class, as well as Brett. Everyone's power is back on, so we'll just wait a second and see if they have any closing remarks. I don't know who's here right now. Okay,
I am in a bit of a Bermuda Triangle myself. Like I quite often lose power in storms, and I think that both of us, it seems like Victoria and I both lost power for about like a minute, and it came back on. Yeah. So.
Well, I'm glad we get to see each other again before we
I know, it was a bit abrupt.
Yeah. Very abrupt.
Well, thank you so much for having me, and thanks everybody for coming back to this call.
Yeah. Well, thank you so much for being here. I know, Victoria, did you have any last question for Dr. Mulligan?
The one that I had Jake.
Oh, not again. Can anyone hear me?